Hello, my name is Austin Miller, and I will be presenting this teaching module to you on the benefits of cannabinoids for pain management in patients suffering from neuropathic pain. These will be the learning goals for the teaching module. From this quality improvement project, you will discuss cannabinoids and their benefits for patients suffering from neuropathic pain, understand the benefit of utilizing cannabinoids to treat individuals with neuropathic pain, understand the potential side effects of cannabinoids, and describe when it may be appropriate to prescribe cannabinoids to an individual suffering from neuropathic pain. So just a little background on cannabinoids and neuropathic pain. So neuropathic pain is a hypersensitivity to abnormal stimuli and nociceptive response to non-noxious stimuli. Over 50% of neuropathic pain patients take gabapentin, but they're unhappy with its pain control. Cannabinoids still are considered experimental, but newer data is proving its efficacy controlling pain in this patient population. Due to legality of the drug over the past couple years, more and more research is coming out, so it's showing that it's useful in many different medical diagnoses. And lastly, cannabinoids' side effects profile may be more tolerable to individuals than traditional treatment methods, focusing mainly on gabapentin. So there's still side effects, but they're different. They're often different side effects than gabapentin. So the reason that cannabinoids can be useful for patients with neuropathic pain and why it needs to be addressed is there's no gold standard for the diagnostic test for neuropathic pain patients, but it's estimated that 10% of the population is suffering from this. And about a quarter up to a half of patients that have neuropathic pain, it's idiopathic in nature. So it's hard to treat the underlying disease because there's nothing really causing it, or it's not known. It's often refractory to medical management, with many patients having inadequate pain control. Gabapentin doesn't always work for these patients. The pharmacological interventions don't work sometimes, and non-pharmacological interventions often fail too. So with lack of definitive treatment, there's potentially millions of patients suffering with day-to-day activities due to uncontrolled pain. So cannabinoids can be beneficial because they have multiple routes of administration. There's inhaled, sublingual, and oral pills available. So how it works is it binds to presynaptic terminal CB receptors, mainly CB1 and CB2. It reduces calcium influx and increases potassium efflux and leads to decreased cellular excitability. This also affects endogenous cannabinoid postsynaptic to be produced and transported retrograde to also bind with presynaptic CB receptors. This in turn leads to analgesia and anti-nociceptive effects. The next slide will have a picture to kind of put it together. So this is more of a visual of what was previously explained on the last slide. So you can see at step 1, this is the neurotransmitter release from the presynaptic neuron to the postsynaptic neuron, which is step 2. So step 3 is the endogenous cannabinoids. So they will, by the trigger on the postsynaptic neuron, it'll trigger to go back to the CB receptor, which is step 4, and inhibit the transmitter release. So then there will be less neuronal signaling, decreasing pain signals. Step 5 is the synthetic cannabinoids, which is what the patient would be administered. So it would work with the endogenous cannabinoids to decrease the neurotransmitter activity. The synthetics work on CB1 and CB2. The endogenous mainly work on CB1. So for cannabinoid efficacy, there's multiple randomized control trials and systematic reviews that show evidence of decreased pain scores in neuropathic pain patients that take cannabinoids. That'll be provided in the references if you want to take a look at specific studies. So inhalational is shown to have a more immediate effect when compared with sublingual and oral. But the sublingual and oral, it's like a week or 2 onset, and you kind of figure out the dose through that. Some patients can't tolerate inhalational, which is why the sublingual and oral is a good alternative. So in addition to decreased pain scores, patients also have an increased quality of sleep and a positive impact on day-to-day lives. So their overall life is improved with cannabinoid administration. The problem with this is these are kind of subjective measures. So pain scores is everybody kind of has a different, it's all relative to how the medication is affecting them. As long as the pain scores are going down, it's considered to be working. However, there is actually quantitative data that has been acquired using a functional MRI and graph theory. It analyzes and found a reduction in network connectivity in areas involving pain processing. So there's actually like quantitative data that shows that there's decreased pain levels in patients after the administration of cannabinoids, specifically in patients suffering from neuropathic pain. Okay, so for cannabinoid dosing, every route kind of has a different dose, as you would expect. So for oral, the main ones are nabilone, which is 0.1 to 1 milligram per week, and then dronabinol, which is 5 to 15 milligrams per day. The studies that focused on these drugs, they tailored them and tapered them over a couple weeks to find what the patients tolerated, like side effects wise, and optimize it with their pain control. The inhalational method, which is the more conventional method that everybody kind of thinks of with cannabinoid administration, it's just different strengths of the inhalational. So there's mainly 1%, 4%, and 7% THC content. And like I said, that varies. And then lastly, there's sublingual. The two main ones are cannabidiol, which is 30 milligrams, and then THC, which is 1 milligram. And these are all, just like the oral, the inhaled and sublingual are also tailored to each patient. So the main focus is cannabinoids versus gabapentin, because gabapentin is kind of the mainstay for neuropathic pain treatment. There's also pregabalin, which is another common medication, but gabapentin is the most common. So cannabinoids are shown to work well as adjuncts to one another with gabapentin, specifically when gabapentin is not controlling the patient's pain level. But many patients stop taking gabapentin due to the inability to tolerate the side effects of this medication. So it can either be used with it, or if they're not tolerating the gabapentin, it could possibly be an alternative. So the side effects, each one of them has side effects. They're different kind of side effects, and some patients tolerate one better than the other based on the studies. So for cannabinoids, the main side effects is difficulty concentrating, impaired memory, hallucinations and delusions, nausea, vomiting, and then breathing problems if they're using the inhaled cannabinoids. The gabapentin side effects is somnolence, nausea, vomiting, and diarrhea, blurred vision and dry mouth, weight gain, and impaired memory. So both of these can impair the memory of the patients and can cause nausea, vomiting, just like many other oral medications. But some patients don't care for the blurred vision and dry mouth, or they're always tired with the gabapentin, so then they just stop taking the medication. So they could possibly tolerate the cannabinoids better, and vice versa. So here are the take-home points for this presentation. Cannabinoids can be an efficacious alternative or adjunct to traditional medication regimens in those suffering from neuropathic pain, mainly gabapentin and pregabalin. Cannabinoids have been shown to successfully decrease pain levels, increase sleep quality, and alter brain network activity to positively impact pain scores and the lives of these patients. Cannabinoids are not the ultimate solution to treating neuropathic pain, as there are still patients that were not satisfied with their pain control after cannabinoid administration. Side effects of cannabinoids may or may not be more tolerable than gabapentin, as this will be individually based. And treatment plans involving cannabinoids must be individualized to patients in terms of route of administration, dosing, side effect toleration, and desired pain goals. This is the first set of references, and this is the last of the references. Thank you for listening to this presentation.